Okay, thank you, and thank you everyone for being here to listen to the final session. I have no conflicts, sadly, to tell you about, but I'm very happy to talk to you about a fairly long process that we've been going through in Australia around improving access to rehabilitation. So just to remind you, those of you who understand stroke, it has devastating consequences that are ongoing and leaving people with disability and dependence. And after the initial sort of hyperacute, mad medical interventions, there is nothing except rehab. So what we were interested in looking at was how to improve access to rehab, and firstly starting with looking at if people are even being assessed to access rehabilitation. This slide is just to remind you of the work that's been done internationally to look at the best times to do rehab, and you can see from the graph this critical period to start rehab early and intensely after the incident stroke. So I just have to move away because I can't read that little thing. We looked at a review of the international practice around assessing people's eligibility for rehabilitation, and the majority of the international guidelines do confirm that everybody should be assessed to see whether they need to access rehabilitation or not. So that's a consensus. And only 13 to 57%, is quite varied, actually then do go on to access rehabilitation. And there was a wide range of kind of criteria that people used to evaluate whether people should get rehabilitation or not. Sometimes based on severity, there's not particularly good evidence for that. If they can't return to the community, that's a pragmatic decision. Weird things like an assessment whether they could learn or not. I don't know how you assess if somebody can learn or not. And there were no real operational definitions. So we embarked on a national process auspiced by the Australian Stroke Coalition. That was, I hope you'll agree, a pretty robust kind of method. And our aim was to devise a process to assess people for stroke rehab that was clear, consistent, and based on best evidence. So we looked at a national survey of current practice at 52 sites. We did a systematic review of the literature, and we had an expert working group of 40 terrific minds across Australia. And we came up with the assessment for rehab tool, which is called ART. And we actually had a fairly radical thing where, look, everybody should get rehab, unless, so we had a default position if they had chosen a palliative course of action, if they refused rehab, or they had a full recovery, or what they were consistently unresponsive. We based it on patient needs, so there was the domains of their needs and not on discipline domains. And we evaluated their level of need according to the sort of levels of services, and we looked at their personal environmental context. So the implementation of the ART, phase one, we didn't know it was phase one at the time, we thought it was was a passive dissemination strategy. We had conference presentations, not unlike this one. We presented at invited workshops in various states. It was put on the website of the Australian Stroke Coalition with a podcast and the manuals to download for free. It was then included in the fantastic Stroke Foundation National Stroke Guidelines in 2010, and now the even better Living Guidelines in 2017. And freely available. It was also included in the National Stroke Services Framework around quality and safety practices, and it's part of the national audit that the Stroke Foundation do in Australia. So that's passive, but I think you'll agree it's pretty comprehensive, but low uptake. So we were frustrated, and the frustration was pretty much everywhere. So we then decided a phase two was necessary, and we were fortunate to have a terrific PhD candidate, Liz Lynch, in Adelaide, who took up the challenge to try a different tack around implementation. The supervision team is myself and Dominique Cadillac, some of you may know, and Julie Luca. We had funding from the New South Wales Clinical Improvement Services, the Stroke Foundation, and from the SA Stroke Network, the South Australian Stroke Network, where we're based. And the aim of this phase two was to compare two different ways of implementing the two different models in stroke units. And we compared multifaceted implementation strategies with a single strategy of education only. So it was a mixed methods cluster randomised trial. We did it across 2 states, and we had 10 hospitals who agreed to participate in the trial, and we randomised them in clusters to either receive the comprehensive implementation strategy or the simple. Our baseline data was around an audit of medical records of patients with stroke, all stroke admissions in the period. So the multifaceted strategy, obviously at 5 hospitals, involved education and provision of the tool, audit and feedback, barrier identification through workshops and strategy development, site champions being identified and empowered, and reminders about the processes to follow. And that was compared to the control condition, which was one interactive education session and the provision of the tool. And then we did a post-intervention baseline again with the audit, and we also did some focus groups with staff. So here's the results overall. This is the combined results across all 10 sites. We went from a 64% rate of being assessed for rehabilitation up to 73%, which is a modest but reasonable improvement. And what the rest of the data there shows is that the majority of that was because the in-hospital clinicians stepped up and actually started to assess for rehab. There wasn't a change in assessment for in-reach assessments. However, it didn't really change too much who accessed rehab, which obviously is our end goal, to get more people into rehab. That only went up by 3%, and not statistically significantly different. So if we compared the 2 methods, there was no difference between the 2 methods. One had 72% and one had 74% as their post-intervention assessment rates. However, the self-reported practice wasn't the same as the audited practice. When we asked people, they said, oh no, we've got 100% assessment now. And they clearly didn't when we did the audit. Now, maybe they're not recording it, but as we all know, audit, if you don't record it, technically it hasn't happened. So this is an issue in implementation, is which sort of data source do we go with. But there was high variation across sites, even with the audit data. And the reasons that people cited to adopt where they did in the sites, I've listed there. They felt it improved teamwork. The process got everybody together and talking about the patient and their needs in the centre. It ensured hidden issues were considered openly, particularly around mood and cognition, and documented. It allowed advocacy for referrals, particularly for people with severe stroke, and allowed a readier and ongoing discussion of when to refer. Reasons that the focus groups gave us that they didn't necessarily want to adopt or continue to implement the tool was that they didn't want to damage relations with their rehab units by referring tricky people, because they thought, well, if they refer tricky people, the rehab units will arc up and not take anybody in the future. They didn't want to set up false hopes with the family, so they didn't discuss rehab options with the family. And you can see, hopefully by my face, we found that extraordinary, that you would think that rehab should be offered, but we'll tell you that rehab's not warranted so that we don't raise your hopes. That they felt the patients weren't motivated or they were too drowsy to participate in rehab, which again, clinically, is not a well-evidenced reason, or felt that they were already doing a good job and they didn't need to change and use a new tool. So we looked at the predictors for implementation, and obviously, and this is no news to those of you who are engaged in implementation, having a site champion was everything. And having an expressed upfront view that they needed to change a priori before we started the intervention. So that therefore they were ready for change, and we did use the behaviour change framework that Linda talked about in the first presentation as well. So in conclusion, a change in rehabilitation assessment practices required buy-in from all stakeholders. We had one entire discipline at most sites who didn't buy in. He actually refused to buy in and said, we haven't got time to talk about rehab in an acute stroke unit. And we needed a pipeline or systems perspective, so that because there was then a perceived barrier in the referral chain into rehab units, we actually needed to work with that next link in the chain to prevent that ongoing or that perceived future barrier. And further work is required to ensure that these criteria are compatible with the values of the clinicians. We uncovered a lot of values around beliefs that actually rehabilitation is not particularly necessary, or it doesn't work, or it's black magic, or all sorts of funny things like this, which we had gone into a little bit blind to that there was still this kind of view. So I think that's about it. If I can just show you the tool, what it looks like is these sorts of domains for those of you interested in stroke rehab, and the sorts of domains that we look at.